Okay, let's go ahead and get started. My name is Doug Sladen. I'm one of the audiology faculty, and today I'm going to review the way that we assess hearing and then also talk to you about some common forms of intervention for both congenital and adult onset hearing loss. Last time, the graduate students were reviewing with you the anatomy and physiology of the auditory system and also some common forms of hearing impairment like ear infections and age-related hearing loss. So today we're going to take that a step further and talk about what happens after hearing loss is identified. Just out of interest, how many of you are interested in speech-language pathology? And how many of you are interested in audiology? Excellent. Anybody interested in something else? Like what?
Human services, social work, kind of just overseeing issues that people might have.
Yeah, social work. That would be a nice niche for people that have communication disorders or hearing loss. Other areas? You raised your hand. Behavioral neuroscience. A lot of what we do is a really good fit for neuroscience because obviously every sensory system ends up at the brain and the brain has to process all of that and do something with it. So that's a really good fit for what we're going to talk about today. Did you raise your hand?
Yeah, I'm interested in
School counseling, yeah, fantastic. Cool. All right, well, I hope that we will make this a casual discussion, and if you have questions along the way, just simply raise your hand and ask. As we talk about communication disorders and hearing loss specifically, I like to go back to this model of spoken language communication that was put forward by Denz and Pinson in 1982. And I like it because it really encompasses every component of spoken language communication from beginning to end. At the very beginning, we have factors that are related to the speaker, the person who's putting out the utterance. In this case, that would be me. So issues that are related to the speaker are things like, how fast am I talking? What kind of language am I using? Am I producing my utterances correctly? Is my articulation good or is it poor? All of that information is then put out into the air. And as I speak my utterances, I'm displacing air molecules in the air around us, and that sound is traveling to you. So the medium at which the sound is being presented is really important. Sound can travel through air pretty well, but it can't travel through water very well. So we can hear pretty well because we have this air-filled medium, but if we were all underwater, everything you heard would be pretty muffled. So the air is pretty important, and how much noise there is around us is also important. So are there things happening outside that are distracting us or creating so much noise that it's pulling away from what I'm saying? And then also how much echo there is in the room. If there's a lot of echo, all that reverberation can bounce around and actually mask out what I'm saying. So this is a pretty nice room. The walls are pretty sound. There's a lot of reflective surfaces, so there's some echo, but it's still a pretty good medium. So the speaker puts out sound waves, speech, that travels through the air and is eventually received at your ear. And your ear takes all that information up to your brain to process the sound. Now hearing, as it is a pretty passive activity. You're hearing me no matter what. Even if you're looking at something else and thinking about something else, you can still hear me. So it's occurring no matter what else happens. And as I'm talking, you can probably hear the projector, maybe hear other people rustling, things moving around you. So it's a passive activity. Listening is an active activity. It's something I have to pay attention to. I have to process sound and devote some of my cognitive resources to processing what's being said. So there's this bottom-up sensory input that's going to your brain, but then this bottom-down, this top-down processing that you're applying to the information that you're receiving. So as you hear me, you're using all of your cognitive resources to make sense of what I'm saying. Hopefully, it makes sense. So there's this bottom-up processing and this top-down processing. And I bring all of that to this environment and to this context. So what I know about language affects how well I can process sound. If I was not a native speaker of English, it would take me longer to process what was being said. So the listener brings a lot to this whole environment. And that's key for what we're going to talk about today, because we're going to talk about some interventions for people with hearing loss that involve both the listener and the speaker. When we measure hearing, we plot it on what's called an audiogram. It's a graph that reflects how well we can hear sound. And the graph is organized so that pitch is along this axis here, going from low pitch to high pitch, like the keys of a piano. And loudness is on this axis here, from soft to very loud sounds. The pitches that are represented are important because these are the pitches of speech. The human ear can hear, between 0 and 20,000 hertz, but speech really only occurs between about 250 and 8,000 hertz. So we don't really have to measure how well you can hear 16,000 hertz or 20,000 hertz because it doesn't really impact your ability to process speech. But we do want to measure these pitches because these results will then tell us how well can you hear the various speech sounds in our language. So low-pitched sounds are things like vowels, like ah and ooh, and high-pitched sounds are more consonant-related, and sounds like S and T and F. So if we plot your hearing levels on this graph, we can then make some broad interpretations about what speech sounds you can hear and what speech sounds you can't hear. This graph is also nice for displaying the sounds in our environment. So we can plot how loud and what kind of pitch environmental sounds are, like the sound of a vacuum, the sound of a motorcycle, and really loud sounds like airplanes going over top. When we plot hearing levels, we do left ear and right ear. And a good way of looking at this graph is to plot the left ear as an X and the right ear as a circle. So here we can see the left and the right ears plotted on that audiogram. And on this axis, I've put in the levels of hearing severity. So anything that is above 25 dB, 25 decibels, is considered normal hearing. Below that, we have the different ranges of hearing loss, from mild hearing loss to moderate hearing loss, moderately severe, severe hearing loss, and then profound hearing loss. To illustrate those different pitches, I'm going to play a couple of them for you. So here is a low pitch sound. This would be 250 hertz. He said with great confidence, if he can get it to play. Here's 500 hertz. 1,000 hertz. Oh, you stinker. Let's do this. Uh, 2,000 hertz. And 4,000 hertz. If any of you couldn't hear that, you should come see me later. So those different pitches broadly represent the pitches of speech. Every audiogram is a little different. No matter which institution or clinic or hospital you're working in, they may plot their results just a little bit different. This is an example of an audiogram from the Mayo Clinic. And again, we have pitch along this axis, loudness down this axis, and the different ranges of severity plotted on your right-hand side. This would be an example of somebody that has normal hearing in both ears. I can see the left ear in the X and the right ear in the circle. And this one is also color-coded so that red is right and blue is left. This person has levels that are well above 20 dB, so we know that their hearing is normal in both ears. Here's another example of an audiogram, but now the X's and the O's are below the normal range, and these are in the range of moderate to mild hearing loss. So this person has hearing loss in both ears, and enough hearing loss that it would affect how well they can hear the speech sounds in our language. So this would be somebody that we would want to intervene with. And if we couldn't intervene with medical treatment, we couldn't fix it with antibiotics or surgery, then we'd want to look at other forms of intervention like hearing aids, cochlear implants, or assistive listening devices. And that's where an audiologist comes into play, is when we can't fix hearing loss with medical intervention, then we fix it with non-medical intervention. That's a bit confusing because a cochlear implant is obviously a medical intervention. The surgeon places the device, but then all the post-operative work happens by the audiologist. I'm going to talk about 4 broad categories of interventions today. The first are clinical trials, things that look at how well we can remediate hearing loss through work with molecules and gene therapy. The second are hearing aids. Third, cochlear implants. And then fourth, I'm going to talk about some modifications that we can make to the speaker that will improve how well a person can hear. Broadly, there are clinical trials going on all over the US and all over the world. Drug companies that are looking to restore hearing through pharmaceuticals. You can imagine that this is a pretty important industry and that the drive to find drugs that can remediate hearing loss would be hugely beneficial. We have a growing and aging population, of which hearing loss is the 3rd most common disorder. And then there's hearing loss that occurs in childhood. And hearing loss that occurs congenitally or at birth is the most common disorder that is present at birth. So about 3 per 1,000 children are born with some form of hearing loss. If we could remediate that through drug therapy, that's a huge industry. There's a lot of money there. So many companies are really focused on trying to develop and bring to market a drug that can fix hearing loss. The first area of clinical trials are related to molecular therapies. Molecular therapies aim to improve hearing by either slowing down the age-related changes to our auditory structures or somehow making our inner ear more resilient to damage. Last time you learned about the structures of the inner ear, that snail-like structure, that's the cochlea, and you learned about the hair cells that line that structure. If we could make those hair cells more resilient to noise damage, then people that were in excessive noise wouldn't have hearing loss as often. If we could make those hair cells more resilient to the changes that happen with aging, then perhaps hearing loss wouldn't occur as often as it does. So molecular therapies generally aim to make the inner ear more resilient and keep off the effects of noise and aging. Gene therapy is a line of research that looks at restoring hearing for people who have genetic-related hearing loss. Genetic-related hearing loss comes from your family. So if there's hearing loss in your family and it's passed on to you, gene therapy could be used to help restore those hearing structures. So if we knew that there was hearing loss in your family, then you could use gene therapy from a very young age to keep off those effects of family-related hearing loss. Stem cell therapy would be used to help regrow damaged or missing hair cells. So in that case, stem cells would be introduced to a body's system with the intent of helping the structures in the cochlea regrow so that they would be functioning hair cells. In my previous career, we were involved in some clinical trials looking at molecular therapies to help keep off the effects of age-related hearing loss. That study came very close to bringing a product to market, but we failed to produce significant results. So we showed that some people had improvements in their hearing, but the improvements weren't significant enough. So at this point, there are no drug trials that have been successful in restoring hearing. I am certain that we will see some form of drug to treat hearing loss in our lifetime, but what it will look like exactly, which form of these it will take, is still unknown. Hearing aids are probably the most widely known form of intervention for people with hearing loss. And they're appropriate for people that have mild, moderate, moderately severe forms of hearing loss. Now, a hearing aid is, at its very best, an amplifier. It makes sounds louder so that they are more loud than what your hearing loss is. They make sounds audible to you. They don't fix your hearing loss, rather they just make sounds amplified so that you can hear them. This is much different than glasses. When I put on my glasses, I've got 20/20 vision. But when you put on a hearing aid, you don't have normal hearing. You just have sounds that are louder in your ear. This is a problem because when sounds get amplified too much, they start to sound distorted. Much like the speakers in your car or at home, when you turn up the volume too much, it starts to sound distorted to you. You've probably all heard this when sounds are really loud. So that's a problem because people have to make sense of this amplified sound, and if it's not clear, it's going to be difficult. In addition, we're introducing amplified sound to a disordered system. These people that are using hearing aids have hearing loss, so there are distortions in their auditory system already. So making a sound louder isn't always helpful because there's distortion at the level of the auditory system. In addition, hearing aids don't know how to selectively amplify sound. So if we were in a huge party and I was trying to hear this young lady here, my hearing aids would be pulling in everything. They don't know that I'm trying to listen to just this one person. Rather, they're pulling in everything around me. And as we have hearing loss, our system loses the ability to separate speech and noise. So that's a huge problem with current hearing aids. If you have family members or friends with hearing aids, they'll probably tell you that background noise is a real problem. And some people even take them off when they get to restaurants or loud places because they just can't manage hearing all that background noise along with the speech that they're trying to hear. If any of you are engineer related or have an interest in electronics, if you could come up with some slick algorithm that hearing aids could use to selectively pull out speech and not amplify noise, you would have a great calling for this industry. Hearing aids are expensive. They cost thousands of dollars, sometimes $2,000 to $3,000 each. That's about $6,000 for a pair. And insurance doesn't always cover hearing aids, especially for adults. So that's a problem. Now we've got this technology that is effective for people, but may not be accessible due to financial constraints. A recent form of hearing aids are called personal sound amplification products, or PSAPs. The attractive thing about a PSAP is that it is affordable. So these often run, maybe $100 or a few $100s. So financially, they're a lot more accessible. They're not custom made to the person's ear. Rather, they have kind of broad amplification that you could just put on anyone, but they're accessible. And so someone who can't afford to get custom-made hearing aids could afford to get one of these devices. And that may be sufficient for overcoming some very mild, moderate types of hearing loss. So I'm a big fan. I like this idea. I like the idea of accessibility and affordability so that everyone has access to improved hearing. I don't love that they're not customized, but I do love that they're affordable. When hearing loss gets really severe, then it becomes so damaged that hearing aids are no longer effective. If those hair cells are completely destroyed, there's really no sense in making the sounds louder because the inner ear is so damaged it can't make use of it. So this is an example of someone that has normal hearing in the low pitches, but then it drops off steeply to level of profound hearing loss in the high pitches. This person might hear vowels but no consonants. And that's a problem because if you can't hear the consonants, speech doesn't sound very intelligible. It just sounds like Charlie Brown speech, like wah, 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 wah. So this person would not have very good speech understanding. In these cases, when a hearing aid is no longer effective, then we can start to think of intervening with a cochlear implant. A cochlear implant is an auditory prosthetic that has two pieces. It has an implantable part that is placed under the skin through a surgery, and then some external pieces that look like a behind-the-ear hearing aid. The hearing aid portion is called a processor, and the processor is able to capture sound, code it, and then send the information across the skin on a radio frequency to the internal device. That signal carries the information about sound, and it also carries the power for the internal component. So the internal component is not powered up unless you've got the external piece on. When the external piece is off, you don't hear a thing. When the external piece is on and working, that sends the information across the skin, powers it up, and then sends information to the piece that eventually gets implanted into the inner ear. The part that's implanted into the inner ear is called the electrode array. And the electrode array has several contacts that thread through that snail-like structure. The idea is if you can place those contacts along that inner ear, along the cochlea, you can then drive those nerve fibers to respond. And because the cochlea is organized with high pitches at the bottom and low pitches at the top, we know that we're stimulating different pitches, a different range of pitches, so that we can represent speech. So this would be an example of a healthy inner ear, where we've got a row of inner hair cells, rows of outer hair cells, and everything looks just the way it should be. Here, in this model, this is a chinchilla who is exposed to really loud sounds, about 90 dB, for 8 hours, 6 months earlier. And you can see that the hair cells are completely missing, or they're so damaged that they're no longer functional. So this ear would not respond to sound. Those hair cells are so damaged that there's no making use of them anymore. Amplifying sounds and using a hearing aid would not work in this ear. This would be somebody that we'd want to consider for a cochlear implant. And the implant would bypass these hair cells and stimulate the auditory nerve fibers directly so the person could hear some level of speech. Are any of you squeamish? Well, it doesn't really matter because I'm going to talk about this anyway. The implant surgery is done obviously by a medical physician, and the surgery takes about 3 hours. It's done on an outpatient basis. So you go in the morning, you have surgery, and then you go home that day. You don't have enough blood loss to have a blood transfusion. You do have to be anesthetized and intubated, but it's considered relatively minimally invasive because you don't lose a lot of blood and they don't have to go very far into your ear to do this. The surgeon makes an incision right behind your ear, then pulls the skin back and drills through this bone. When they get to the inner ear, they thread that piece into your cochlea, place the electronics up here under your skin, and then close the whole thing up. So from a surgeon's perspective, they would consider this relatively not very invasive. From our perspective, it sounds pretty severe. I mean, they're going to open up my head and drill through some bone. That sounds pretty invasive to me. But from a surgeon's perspective, they don't consider this very invasive. This would be a picture of somebody that's getting ready to have cochlear implant surgery. In this case, they've shaved this part of the head, and then they've sterilized it, and they've placed a sterile sheet over here so that nothing can get into this area that could be infectious. This is a pretty old picture. They typically don't shave the head anymore. You don't need to. In these days, there was a lot of caution taken to make sure that no hair would get close to the incision site, but that's pretty uncommon now. You can see the surgeon has marked where they're going to make their first incision. So they're going to make this kind of S curve here, then they're going to pull this skin back. If we could skip forward through the incision, through all the drilling, we would eventually see this perspective here, where we're looking through the mastoid bone, and this hole right here on the other side is the inner ear. So it's not a very big space. And it also really drives home the idea that the inner ear is not this standalone structure that you can then visualize, but rather it's encased in bone. So when the surgeon goes to implant the electrode array into the inner ear, it goes in blindly. The surgeon sees it going into the hole, but then they don't see it anymore. They lose sight of it. And it goes into the bone and then coils around the cochlear structure. This is a close-up of that viewpoint. The inner ear is right beyond here. This is a round window that connects to the inner ear. It's a membrane that goes to the inner ear. The surgeon could implant the array through that membrane. He or she would make a small incision and implant the array through there. Or they could drill through this bone and create what's called a cochleostomy. It's a hole in the cochlea, cochleostomy. And then insert the electrode array there. Once the array is in place, it looks like this. So again, you can't see that the array is coiled up into the inner ear. We just have to take it for, we have to take the surgeon's word that it went in smoothly and hope that it's in the right spot. Before they let this patient wake up, they would bring in some radiology folks and do an x-ray to make sure that the array is in the right spot. You can do what's called a plain film x-ray, and if you see the array spiraling up like this, then you know you're in the cochlea. If the array is just a straight line, you're not in the cochlea. You're probably somewhere else. It does happen once in a while, but it's pretty uncommon. The external pieces have changed considerably over the last 3 decades. The first cochlear implants were done in 1982, and since then, the external pieces have been miniaturized and digitized to the point where they can be very small and more discreet. The first processors were these big box-like things that you'd have to wear on your belt, and there would be a cable that would go up to your ear to transmit the information across the skin. They became smaller and smaller and smaller, and eventually They became small enough that you could hang them on the back of your ear. The current devices look like this. So there's a processor. The bottom part is a battery. There's a cable, goes up to this piece that's a transmitter that transmits the information across the skin. This is another example. There's the processor, there's the battery, the cable, and the transmitter. These ones are newer, and they're called off-the-ear processors. They just look like buttons that stick to your head. The internal piece has a magnet, and the external piece has a magnet, so it sticks to your head by magnetic attraction. The only function of the magnet is to keep it on your head. Everything else happens electronically. There's no connections that go through your skin. So when you take it off, you can shower, you can bathe. There's nothing you can see that would make you know that you had a cochlear implant. The outcomes from cochlear implantation are amazing. These are some data that I collected a couple of years ago looking at consecutively implanted post-lingually deafened adults. That means that the people were deafened after they learned spoken language. So they already had a mental representation of what spoken language was and then lost their hearing. These data are broken down by age groups. So we have adults that are less than 60 years of age, adults that are 60 to 69, 70 to 79, and then 80 plus. What we're seeing along the x-axis are their scores when we tested them with their hearing aid before surgery. This test is a single word test. So the presentation may sound something like, say the word ball, say the word dog, and the person would reply back. They would say ball or dog. If they got it wrong, then of course they would get 0. We can score that test as a whole word, or we can score it by the number of phonemes that there are. There are 3 phonemes in a monosyllabic word. Ball has 3 phonemes, b, a, o. So we can score that as a whole word correct, or number of phonemes correct. So if the presentation was, say the word ball, and I said bald, I would get credit for the b and the ah, but not the ald. This test is a sentence test. So the presentation might sound something like, the boy ran down the road. And the person being tested would be expected to say that back. They get scored for the number of words they get correct. So if they said, the boy ran down the path, they would get all but one of the words in that sentence. So these are their data with their hearing aids preoperatively. And you can see that everyone's scoring pretty poorly. These people are scoring on average about 15% correct. It's a pretty easy test. You're just saying, say the word ball, say the word dog. So they have so much hearing loss that they're not able to get just that single word. Their sentence scores are a little bit better because you can hear just a couple of words in a sentence and start to fill in the gaps. So if the sentence was, the boy ran down the road, and I heard boy ran down, I might say, well, the boy ran down the road, just as a guess. But because I could get some pieces of information, I could fill in those gaps. So sentence scores tend to be higher than word scores. These are their data at 12 months after having cochlear implant surgery. If we were to take these scores and collapse them, we would see that adults who lose their hearing later in life score on average about 67% correct 1 year after surgery. And they started at about 15% correct. So the outcomes are profound. You're taking someone that has relatively no hearing, no usable hearing, and partially restoring it, enough that they can hear speech so that they have great improvements. So you can imagine that this person is having probably a much easier time understanding speech than they did before surgery with their hearing aids. What's of interest is that the scores are different for younger adults compared to older adults. This speaks to the idea that older adults have damage to their hearing structures, but they also are facing damage to the way that they can interpret or process sound. So older adults tend to be slower in processing sound, and there tend to be more central effects that we can't overcome with a cochlear implant. These are data for hearing speech and noise. When we think about testing speech and noise, we want to know how loud does a speech have to be above the noise in order for us to hear it 50% correct. For those of us with normal hearing, we're probably able to hear speech when speech is equally loud to noise. But somebody with hearing loss needs the speech to be much louder than the noise in order to hear it correctly. So people with hearing loss tend to need a greater signal-to-noise ratio to hear speech accurately. So on this graph, we see on the y-axis a signal-to-noise ratio. How loud is the speech over the noise? And on the y-axis, I've plotted the different age groups. So the younger adults and then the oldest adults. The blue marks show the hearing levels before surgery. So this is how loud they needed the speech to be above the noise in order to hear it 50% correct. And then the lower scores are from their 1 year post-activation, post-surgery test interval. And you can see a dramatic change in how loud the speech needed to be for the people to get 50% correct. So it could be much softer and they could hear it accurately through their cochlear implant. So the effects of cochlear implantation are not only just for quiet listening conditions, but also for complex listening conditions like listening in excessive background noise. The sound that comes through a cochlear implant is pretty crude compared to what we can hear with normal hearing. Remember that with a normal functioning inner ear, we can hear a huge range of different pitches. But with a cochlear implant, there's a finite number of electrical contacts that are placed in the ear that are then driving those auditory fibers to fire. The number of contacts you have is directly related to how successful the implant may be. The very first cochlear implants only had one electrode, and they weren't too successful because all the people could hear was kind of the rise and the fall of speech. They couldn't hear the detail in speech. They couldn't hear enough detail to make sense of what was being said. So they got presence versus absence of sound, but they didn't get good speech understanding. So these are some examples of simulations of a cochlear implant, of different numbers of channels inside the inner ear, and then what the actual signal was. So here, I want you to listen to these sounds and see if you can identify any words in this sentence. And again, this is just a simulation of what a cochlear implant would sound like. We can never truly know what an implant sounds like because it goes into somebody's ear, and everyone's ear is a little different. So how much hearing loss you have, how many surviving fibers you have, how long you had hearing loss, where the electrode is sitting inside the inner ear, all those variables lead to a lot of heterogeneity in what people are actually hearing. So these are simulations. They're our best theoretical understanding of what's coming through the implant. So here's one channel of stimulation. I'll do it again, a little bit louder. Whoops. Could you hear any words? No, so you could hear the rise and fall of speech. I heard wah, 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 wah. Here's the original sentence.
The boy did a handstand.
Okay, I can hear that. So the wah, 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 wah. The boy did a handstand. Here's two channels, we hope. About the same. So I couldn't really hear much there. Here's the original.
The silly boy is hiding.
Never would have got it. Here's 4 channels. Can anybody hear any words? It's more intelligible though, hey? Like, even though you couldn't understand it, you could hear an improvement in the intelligibility of the sound. I heard the sentence, but I've also listened to these a gazillion times. I think it's the dog growled at the neighbors.
The dog growled at the neighbors.
Here's 6 channels. Yeah, the tree fell on the house, that's right.
A tree fell on the house.
And here's 8 channels. The husband brought her flowers, yep.
Her husband brought some flowers.
Yeah. So at 4 channels, I could hear it, but I've got some experience with synthesized speech. But I think you could also appreciate that it was starting to sound more intelligible. What we've learned about cochlear implants is that you need at least 4 channels for speech to be intelligible. And then the more channels you have, the easier it is. Our problem is that once we get more than 8 channels into the inner ear, the performance starts to plateau. It's likely because we're putting electrical current into a fluid-filled system. The inner ear is filled with fluid. And we've now got very small bits of electricity going through there. It's not a lot of electricity. It's not like you get a shock. You would never even feel it. But it's enough electricity to drive a neuron to fire. And there's enough electricity that it can spread around. Remember that electricity in fluid is being conducted all over the place. So what happens after you get more than 8 contacts in there is that all the electricity is kind of moving around and it distorts the signal. If we could somehow make the contacts more specific or only stimulate this one region and not spread around, that would improve how many contacts we could get in there, and that would improve overall performance. The most recent work to do this is to use a high-rate laser beam to drive those neurons to fire. So instead of using electricity, which spreads around, use a high-rate laser beam at low levels so it doesn't burn the tissue, and use that to drive the neurons to fire. And that way, we might be able to get more contacts in and get more intelligibility out. Still, the reason that cochlear implants are successful now is that we're implanting them into people that already have a mental representation of speech. So they're people that lost their hearing in life. So even with 4, 6, 8 channels, you could hear it because you have some knowledge about spoken language. If you did not have any knowledge about spoken language, you wouldn't be able to do this task because it wouldn't be meaningful to you. So implants are successful because people are bringing their own experiences to the sound that they're now getting. It's not perfect, but it's enough that they can pick out bits and pieces and their brains can fill in the gaps. So you can use your knowledge about language, your vocabulary, your world experience to help add to the contextual value of what's being said. The very first implant candidates were adults that lost their hearing in life. And when they were successful, we started to implant children who were deaf. The very first children who were implanted were older children and the very deafest children. And that was done because we weren't really sure how they were going to work out. So we wanted to implant them in children who could tell us what they were hearing, as opposed to a very young child who doesn't have any language and can't say what they're hearing. And we also wanted to implant them in the deafest children because we didn't want to sacrifice any usable hearing that they may have. So even if they had just a little bit of hearing, then we wouldn't want to compromise that by putting an implant in there. So the first implanted children were the older children and the deafest children. In hindsight, that was absolutely the worst decision to make because these children had already passed the critical period for learning how to process sound through their ears. The current guidelines for implanting children are to implant children at very young ages. And a lot of this data was collected by a group from Johns Hopkins looking at the age of implantation and how successful those children were. So I'm going to show you some results from a study that's pretty important in our field, and it's important because this was a large group of children, and it was published in a very mainstream journal, the Journal of the American Medical Association. In this study, there were 188 children from centers across the US. That's also important from a scientific perspective because multi-center studies help us know that we can generalize the outcomes to a broader population. These were children who were all implanted prior to 5 years of age, and they were compared to 97 children who had normal hearing. The outcome was performance on a language scale called the Reinel Developmental Language Scale. In addition, all these children scored in the normal range on the Bailey Scale of Infant Development and the Leiter Performance Scale. That means that they were all developing on a normal trajectory other than the fact that they had hearing loss. So cognitively, they weren't impaired. They all had normal developmental function. This graph shows us their comprehension scores, so how well they could understand speech. And what you see are 3 panes, a pane with yellow, blue, and with green. The children in the yellow pane were implanted before 18 months of age. The children in the blue pane were implanted between 18 and 36 months of age, and the children in the green pane were implanted after 36 months of age. The children with normal hearing are shown in the black marks here. What you see is that for each pane, there are individual lines. That's showing each child that was in the study and their trajectory of performance with their implant after implantation. So these children who were implanted youngest, we see that the start of their lines are all down here at a very low point because they were implanted the youngest. These children, their lines don't start until here because they were implanted older. So where their line starts is when they entered the study, their age at which they entered the study. What you see is a lot of variability. So some children perform really poor, and some children perform very well. And that is true for each pane. The amount of variability, however, is much greater for the children who were implanted at the older ages, meaning that the outcomes were more heterogeneous when children were implanted at an older age. What you'll also notice is the mean line right here. So this is the average trajectory performance for each age group, and you can see that for the youngest implanted children, that line is the steepest. So if you look at this line compared to this line is steeper, meaning that children are getting better faster. That's a really important finding because we want children with hearing loss who have chosen the spoken language communication route to be able to function using spoken language fluently and proficiently by the time they get to school age. So if children implanted younger get better faster, then it's more likely that they can be mainstreamed by the time they reach school. This finding was true for the way that children could understand speech in their comprehension scores, and it was also true in their expressive scores, so what they were putting out, what spoken language utterances they were making. So we see a steeper acquisition of language for the youngest implanted children compared to the older implanted children. So these data are huge in our field because they demonstrate really well that if you're going to implant a deaf child with a cochlear implant, you need to do it at an early age. If you wait until a child is older, you're likely going to miss your opportunity for maximizing performance. There are other data that show us if we implant a child over 7 years of age, that brain is already so reorganized that it can never make use of auditory information. So those children tend to be non-users. So if you're going to implant young children, we need to do it at an early age. All right, this is an interview of a mom and a child who had a cochlear implant. And I want you to pay particular attention to the child's language and her speech. And remember that 30 years ago, this child likely would not be able to speak at all.
The first sound I heard was probably
And then after all the beeps.
and then after all the beeps, I heard you.
I love you.
I love you. What did you first think when you learned I was deaf?
That's a good question. So actually, your mom and daddy, we were very excited.
Really?
Yeah, do you know why?
Why?
Well, we took you home after you were born. You were struggling to learn how to breathe and walk and talk. And Mommy and Daddy had lots of people that used to come over to our house, like occupational therapists and physical therapists and speech and language pathologists and feeding therapists. And when you were 8 months old, you passed a hearing test. And so we thought, okay, so she can hear, but something else is wrong. And so for 10 months, we didn't know what else was wrong until we took a second hearing test. And do you know your audiologist, Erin? Do you remember Miss Erin? She was there with us, and then she sedated you and gave you a hearing test. She put you to sleep and gave you a hearing test, and she said, you know what? Zoe is profoundly deaf in both of her ears.
What does profoundly mean?
That means that you couldn't hear anything,
Not even a sound.
not even a sound.
What are the other types of deaf?
There's mild, moderate, severe, I think, and then profoundly, which is no sounds.
Okay.
And that was you. And then we were actually relieved because we thought maybe there was something else going on.
Okay.
So we were pretty happy.
Okay.
Yeah. Because we knew there was something we could do about that.
Okay. So what strikes me there is the young girl's efficiency and proficiency with spoken language and her articulation. If we didn't know that she had a cochlear implant, I wouldn't identify her as having hearing loss. I can't hear deaf speech in her voice. It doesn't sound like it's hearing impaired to me, which is huge and life-changing. And it's an important technology for children who have hearing loss because children with hearing loss are often born into hearing families. 97% of deaf children have hearing parents. They don't have deaf parents. That's an important statistic because children and parents need to share a language. Not only are the parents their primary language model for their children, but there are huge sociocultural implications of not having the same language as your child. That child can then no longer communicate with their uncles, their grandparents, their aunts and uncles. So children and families need to share a language. Hearing parents could learn sign language, but data shows us that only about 17% of hearing parents who have deaf children actually become fluent in sign language. So there's this huge disconnect where children who are born deaf and remain manual communicators don't share language with their extended family. And that has implications for their own development. Cochlear implants provide an opportunity for deaf children to have hearing and share a language with their parents, which I think is critical. Okay. So we've talked about Clinical trials for drugs to remediate hearing loss, hearing aids we've touched on, and we've also touched on cochlear implants. The last form of intervention that I want to share with you are adjustments to the speaking style of the speaker and the environment. The way that a person talks has huge impact on how well that message can be understood. And as we were saying before, the rate of production has a huge influence on comprehension. There is a speaking style that's called clear speech, in which speakers are instructed to slow their rate and pause in natural places. And by doing so, you do a couple of really important things. One is you slow down your productions so that it gives the person who has hearing loss more time to process sound. Remember that people with hearing loss are likely listening through a hearing aid or a cochlear implant, and that the sound is not perfect. It's likely degraded. And as such, they need more time to process and make sense of that signal in order to decode it. So by slowing down our rate, we give people with hearing loss more time to process sound. In addition, if we slow down, we tend to elongate our words. And as we elongate our words, we make that sound more salient. We make it richer. So clear speech, when produced correctly, elongates vowels, creates longer target word durations, and makes sounds more salient. What I love about this technique is that you can all do it. You can do it with your grandparents or your friends or family who have hearing loss, and you'll see an immediate benefit in how well they can understand you. My grandmothers both lived to be 99, and when I would pick up the phone to call them, I would forget to slow down my rate. And I would just launch into a conversation and say, "Hi, Grandma, how are you?" And the response would always be, "Who is this?" And as soon as I would slow down my rate, they would be able to understand me almost perfectly. Producing clear speech also has benefits for people who don't have hearing loss but who are non-native speakers of English. Again, people who are non-native speakers of English need more time to process sound. And as you slow it down, you give them time, and you also make the signal more salient. It gives them more information to hold on to process and decode. So it's important for people that have hearing loss, important for people who are non-native speakers, important for young children who have immature auditory systems, and important for older adults who need more processing time. So here are a couple examples of producing clear speech. In the first example, this is just regular conversational speech like I'm producing right now. We hope. Let's try. Oh, my computer is very mad at me. I got the spinning circle of death. Well, let me produce it for you. Conversational utterances would sound something like, "He looked at the cheese," whereas a clear speech production would be, "He looked at the cheese." That sounded cheesy the way I said it. The recording is much better than what I just did, but the point is that you want to pause in a natural place. So he looked at the cheese. You wouldn't want to pause in an unnatural place, like after the word he. You wouldn't want to say, "He looked at the cheese." You'd want to pause in some sort of natural spot. And then by elongating the utterance, the target word being cheese, you make that space larger and, as I said before, more salient. Thanks, Tim. So this is a nice thing to do because, as I said before, you can all do it. You don't need any sort of fancy technology. It's something that we can all do to improve communication with our communication partners. Even for folks that are normal hearing, if you're out in a loud bar and the person next to you is having a hard time understanding what you're saying, just simply slow down. And you'll see that their intelligibility and their understanding likely goes up. I can feel my whole body relax when somebody slows down. It just makes it a lot more salient. All right, so this was good timing because we are at the end of this lecture anyway. So let's open this up to questions. And any questions you have about hearing, hearing loss, hearing aids, drug trials, cochlear implants? Yes?
When they do drilling for the cochlear implant, how do they like find that perfect spot?
Yeah. Okay.
He looked at the cheese. He looked at the cheese.
There you go. Okay. Thank you. Excellent. Good question. So how do they know where they are? Their surgeons are really skilled at identifying landmarks along that whole pathway. They know the anatomy so well that they, even though it may look like a blur of bone to us, they can see subtle changes in the density and the structure of the bone that they know exactly where they are. They can even identify when they're getting close to really important structures like the facial nerve or the auditory nerve. Typically, the patient has electrodes placed on their head so that when you get close to those nerves, it starts to beep really loudly to you. And then you move away from that spot. Yeah. Other questions? Yes, sorry.
In that one graph where it was noting hearing loss in different age groups, it's the age group from 70 to 80
Yeah.
had the most profound hearing loss. Why do you think that is?
So that graph was showing us performance on speech perception tests for different ages. Yep, so those people likely all had the same level of hearing loss. The amount of severity of the loss was probably the same. What was different was how well they could process sound.
But why do you think the age group 80 was performing better?
Yep, for sure. So what we know about older adults is that they have decreases in auditory function, not only because of what's going on in the cochlea, but also what's happening higher up. So we see a loss of neural transmission and a loss of speed of processing. So older adults tend to have more central effects of hearing loss compared to younger adults. So that's why we see those age differences. Yeah.
So when people are getting tested, like for the sentences and stuff, do they get to look at the speaker to like read their mouths, or is it like strictly hearing?
Good question. So the question was, when people are doing these tests, is it auditory only, or is it auditory and visual, right? And I should have made that clear. These tests were all done in the auditory only condition, so they weren't able to see the person's face. You could argue the benefits and the disadvantages of that. The benefit is that we're just isolating the hearing system, and so I can truly know how well can you hear without adding on some complexities about how well can you hear and see. But the flip side is that we don't communicate like this, we communicate like this. And so to get a really good ecologically valid measure of human spoken language communication, it should be done in the auditory visual condition. So typically in a large cochlear implant program, we would do tests in the auditory only condition and then the auditory and the visual condition. So we could see how much is added by adding line of sight.
And is that statistically like much different?
Always. Yeah, adding vision always makes things a lot better. And you'd be amazed at how well some people with hearing loss are at using their visual system to fill in those gaps, taking advantage of all those nonverbal cues. I've come across people who seem to have really good spoken language communication, but then when we remove the visual condition, they just fall apart, which really drives home this idea that they're using their visual system a lot to make sense of what's going on. Yeah.
So say a person gets a cochlear implant, can you speak more about the audiologist role like after that?
Yeah, good question. So the question was, I speak more about what happens in the audiology office after a person gets implanted. The implant surgery is done, and then the person waits about 2 to 3 weeks before they come into the audiologist's office to have the external piece fitted to their ear. And the reason we wait is because there's a lot of swelling. And the only way that the external piece stays on is by magnetic attraction. So if there's too much swelling, then the external piece will just fall off. So once the swelling has gone down, they come into the office. We make sure that it stays on their head with enough retention that it's not going to fall off from simple walking or even jogging. They should be able to do a light jog and it's just stay in place. The audiologist then sets the minimum amount of current needed to get the person to hear. So what I mean is, if we put in a little bit of electricity, it may be too little to make those neurons fire, and so they're not hearing anything. So we raise the current up and take it up and up until they say, oh yeah, I can hear that now. And what they're typically hearing is like a beeping sound. Beep, beep, beep. When they can hear it, we stop. We then make those beeps get louder and louder to the point where they say, okay, that's loud enough. I wouldn't want it any louder. And so what you've done there is you've effectively created this dynamic range between the threshold of hearing and the upper limit of hearing, and then all the sounds that come in through the processor are mapped into that dynamic range. You do that for every single contact. So there's 22 contacts in one of the devices and 12 in another and 16 in the other. So you can imagine you have to do a lot of work to create that dynamic range on every single contact. In young children, we typically put through current that gets loud enough that we can generate an electrophysiological response. So we can record a waveform that deflects when there's enough neural firing. And we use those responses to guide where we're setting our results. Because obviously a 12-month-old can't tell you, oh yeah, I hear it now, and oh yeah, that's too loud. So you have to use objective measures to set those responses. Good question. Yeah?
When a cochlear implant is implanted like in a young child, does that have to be updated as they grow older or like as they're growing at all?
Yeah, another good question. Gosh, you guys are sharp. So the question was, does the implant have to be updated? There's two sides to this response. One is that we've only been doing implants for 30 years. So we expect that the implant, the internal implant, should last the child's lifetime, but truly we don't have 100 years worth of data to know that a child implanted now will be able to use that device when they're 90. So if a parent were coming in today and asking about, will this have to be replaced at some time, I would be really cautious and tell them to likely expect that at some point in your child's life, they'll want to have it replaced. But truly, we don't have enough data to know that. The external piece gets updated every 3 to 5 years. You've seen the changes in the external processors. They went from really big to really small. And those changes happen every few years. When those changes happen, it can always be upgraded no matter what internal piece they have. So people who were implanted 20 years ago can still use the most current external pieces. Yeah. Yes?
So I know that cochlear implants are really like a huge controversy in the deaf community. How do you go about like trying to convince somebody who is like really strong in their opinions about not getting a cochlear implant? Like
right.
The benefits would actually like help them. Like how do you go about that situation?
Yeah. So the question was about the deaf community and the debate between the deaf community and the hearing community on cochlear implants. I would say that the debate is not very strong these days. The debate used to be really strong, wherein the capital D deaf community would accuse the hearing community of committing cultural genocide, of implanting young deaf children, and by therefore removing the next generation of congenitally deafened manual communicating adults. And they were right, because this is somewhat eradicating deafness. But my response is that parents of children who are deaf, who don't know sign language, need to have a language system with their child. And if they choose spoken language, then I support that 100%. If that same family thinks, you know what, I don't want to implant my child, I want my child to stay deaf and use manual form of communication like sign language, that is also fine, and that is perfect for that family. But every family should be given the choice whether or not they want to use spoken language or manual communication. My impression is that most families with deaf children want their child to be able to hear them, and so they choose cochlear implants. There's definitely geographic influences. So in parts of the country where the deaf community is very strong, most of those deaf children stay deaf. And in other places where the deaf community is not as strong and there's more of an influence of cochlear implants, you see a higher rate of children being implanted. For adults who are deaf, adults who have never heard anything, a cochlear implant is not a good idea. So if somebody who is deaf and 18 years of age came into our office and said, I want to get a cochlear implant, I would say no. It's not a good idea. You will never be able to understand speech through that device. It's an invasive surgery that you don't want to have to take the risks of for very little, if any, benefit at all. It's a great technology for the right people, for the people that fit those criteria, and for the families who choose that form of communication. Hope that helps. Other questions? Sir?
If like an older adult experiences severe profound hearing loss, do you see like a pattern of how their speech decreases? Like if they can't hear themselves, does their speech decrease over time? Or does it stay consistent?
Yeah, so if an older adult loses their hearing, what happens to their speech production? Is that correct? So people who are normal hearing and lose their hearing later in life have a greater chance of kind of maintaining their own productions. But eventually you'll start to hear some changes. So you'll start to hear a rise in their own productions. They may start to sound louder than their peers. You may also start to notice that they lose their S sounds because they can no longer hear themselves producing it. And they may also become more nasalized. People become more nasal because you can't hear the rise and the fall of the velum in the back of your throat. And so people with a lot of hearing loss often become quite hypernasalized. Yeah. Okay, well, thank you very much for your attention. And if you have other questions, come find me.